Great. Well, welcome everybody to, I think, our third Thursday brown bag, Thursday GHB brown bag. It's my great pleasure to introduce our presenters today. It's going to be, if I understand correctly, and correct me if I have this wrong, it's a joint presentation by our own Professor Winnie Yip, Professor of Global Health Systems and Economics and Principal Investigator of the India Health Systems Project and Director of the China Health Partnership, and many other things besides, and Dr. Annie Hackenstad, graduate of our own program, former postdoc here in GHP, and currently assistant professor in the Department of Health Metric Sciences at the University of Washington. They're going to present today on how Odisha's healthcare system performs, and this is part one of a two-part presentation: financial risk protection and the interaction between public and private providers. So you have to join us also for the sequel next Thursday. It's going to be very exciting and fascinating, and so let me hand over to you, Winnie, without further ado.
Great, thank you very much, Kevin, and also for the department for this opportunity to our projects work with colleagues and students. If my voice starts breaking, then just tell me, and I will see what I can do. So let me give you a little bit of a background. As Kevin said, it's going to be a joint presentation. It's because it's representing work that is done by the whole team, and so I would like everybody to be a part of sharing the great work they have been doing. So the work started about 3 years ago when in India they were thinking about healthcare reform, but at the same time they were a little bit unsure where to start and how they should prioritize. And then at the same time, the Gates Foundation was recognizing that despite a lot of money that they're spending on vertical program, disease-specific program, they're not seeing a lot of impact. So they feel that the fact that the yes, it's, maybe you can mute yourself. You're not speaking.
Yes.
Okay.
All right.
Creo que no. Gracias.
Everyone can mute that's not speaking. That would be wonderful.
Sí.
Yes, thank you. And so it was a time that when the Gates Foundation and also a group of intellectuals in India begin to feel that maybe vertical programs or disease-specific investment alone will not be producing result unless the health system itself is functioning. So it's against this context and background that our work started. So Odisha is a state that is on the eastern border of India. It's one of the lowest income states. And I tend to have a tendency to go to the lowest income province and state in every country. And I think that partly is both, of course, our motivation that if you can have any research findings that can contribute to policy, that would be where the greatest benefit is. Next, please. So today I'm going to give you an overview of the project, but also start with just saying a bit what is the approach that we adopt, and then the key findings. And then Annie will take one part of the findings and go into much more depth. And then next Thursday, other team members will talk about different parts of the finding, again, going into much more depth. Next, please. So let me start with telling you a little bit of the goal of the project. The goal of the project is very straightforward. It's really to improve Odisha's health system, and to do what? To provide affordable and equitable access to care of some quality standard, but also while avoiding major financial risk. And we did it in Odisha, but the idea is that the lessons from Odisha can be drawn for other states as well. I think most of you who work in India or know India is that health is a state matter. So a lot of the initiatives is actually started at the state level, and that's one reason why we work with a state, but we have communication with the national level so that the results can be shared. This approach that we adopt, I would call it, is a systemic approach. So next, please, and let me elaborate a little bit what I mean by that. So basically, instead of going in and telling a state or country to say that this is the reform you should do, we actually start by identifying what are the problems in that state or health system. And so if you look at the right-hand side, where under the red circle, this is the sort of the process that we use. We always start with doing a health system assessment to look at where they do well, where do they not do well. And the next step is trying to understand where we call it diagnosis, trying to understand why that country or healthcare system is doing not well in a particular outcome measures. And by analyzing the causes of poor performance, that provide the evidence base to then propose reform options. And then, of course, reform options is a technical proposal that would have to go through political decision. And our idea is that once the politicians and the government leaders made a decision of our reform options, then they can implement it while we will continue to help them to do monitoring and evaluation and then so on. So our project was actually proposed for the entire reform cycle. And what we're presenting today is mainly the first two steps, the assessment and also the diagnosis. And the framework that we use to guide our analysis is shown on the left-hand side, what we commonly call the control knot framework. And many of the students who have taken my course or Tom Boss's course should be familiar with that. So this framework is basically saying that a health system is a means to an end. We're not interested in counting number of hospitals, number of physicians, how much money is being spent. We're interested to look at how well a health system performs in terms of outcome that matters for people. And what are these performance goals? Ultimately, of course, we care about health status, financial risk protection, and also people's satisfaction. And also the distribution of that between the rich and the poor, people of different socioeconomic status. But we also care about some what we call intermediary goals like quality, access, and efficiency. We call them intermediary is because ultimately it is not, people don't really, and ultimately these matters because they also produce, they are important in producing financial risk protection, people's satisfaction, etc. And so these will be the performances that we start measuring and assessing. And then once we assess them, we will trace back to the 5 elements in the healthcare system, which has been identified as financing, how providers being paid in terms of provider payment, the organization of the delivery system, regulation, and other behavioral interventions. So I won't go into detail of that, but this is just providing you with the logic of how we approach it. Next, please. So let me then now talk about how do we gather the information to do this study. In most countries that in India and in most countries that I have worked with in, there's one common problem that is usually existing data do not provide the comprehensive information for you to do a systemic level of assessment. In the case of India, what they have, which is shown on the left-hand side, is they have huge data set, but they're mostly household level of data, which means that they're mostly representing the demand side. But India has a huge private sector. Very little information is actually collected on the private sector. And if so, maybe for just the private hospitals in small samples, but the large number of private providers that is providing outpatient care, primary care, is very much unrepresented. A lot of study actually focuses on quantity, that is counting visits, counting utilization, and very little information on effectiveness or quality. So what we do is that we actually develop 10 surveys to try to fill those gaps. And the 10 surveys include household survey and survey of all the types of provider for the public sector, hospitals, community health center, primary care units. For the private sector, again, hospitals, solo provider, and also chemists, because lots of people go to chemists, not just to buy drugs, in fact, to get care. We also map out the location of the providers and try to do market studies and analyze by past behavior. And we also have extensive work that is focusing on various aspects of quality. In fact, the next week's session is going to be very focused on effectiveness and quality. Next, please. So let me just give you some punchline of the main findings so that then I would then turn to Annie to go into depth a little bit more. Next, please, Annie. One key finding is that financial risk protection is really poor in Odisha. Nationally, about 16% of the population face catastrophic health expenditure measured at 10% level, threshold level, and Annie will go into that a little bit more. In the case of Odisha, 24% of the household in our sample face catastrophic health expenditure, and 10% of the household are pushed into poverty because of spending in healthcare. And what surprised a lot of people, including our Indian partner, is that the major driver for catastrophic expenditure is actually not hospital. It is actually outpatient care and also spending on drugs. So where do people go to get outpatient care? In our sample, about 46% of the people go to public sector for outpatient care. Another 54% of them go to private. And among those who go to private, a majority of them actually go to chemists. And of course, when you go to private, outpatient, or chemist, there are quite a bit of drugs that are being prescribed. And if you look at this table, what is interesting and surprising is that even among those who go to public sector, about 72% of them would afterwards go to a private chemist to buy drugs. And which means that if you look at the total, everything together, almost every person who had an outpatient visit would have had some contact with the private sector. And spending on drugs represents the largest share of their spending. And it is becoming a major driver for catastrophic expenditure. And I'm going to let Annie go into that a little bit more later on to understand what might be the underlying reasons why people go to the private and why they're spending so much on drugs, and the implication of India's current major healthcare reform, that is, India's current public insurance program actually doesn't cover outpatient care. So next, please. The second key finding that we find is that poor quality of care is just so prevalent. Here is data presenting studies that use vignettes to test for providers' knowledge. This is just knowledge, okay? In terms of the 5 common outpatient health conditions: tuberculosis, preeclampsia, diarrhea, heart attack, and asthma. And we interview both public sector and private sector. And if you look at this diagram, if you look at the table, this is quite worrisome and depressing that the percentage of correct diagnoses for tuberculosis is only 40%, and the highest will be diarrhea, which is still 72%. And if you can't even diagnose it correctly, so how can you say whether they can treat correctly? The second column shows that even among those who have been diagnosed correctly, the percentage that give correct treatment according to guidelines, according to clinical guidelines, it is only single digit, and many of them are 0. But they prescribe a lot of drugs. The percentage who actually prescribe at least one correct drug is tiny. Again, if you look at it, it's varying from 50% to 70%. And the last column shows that providers who give only unnecessary and incorrect drugs, that is, none of what they prescribe is actually correct, is quite high and quite variable. And this is very worrisome because we're telling you that people actually suffer from catastrophic expenditure because they spend a lot of money and they spend a lot of money on drugs. And this slide is saying that they're spending a lot of money on drugs that is actually not helpful or useful for them. And a lot of them is in the private sector. I'm sure many of you who work in the public sector know that, who has worked in India knows that many policymakers in India still look at the healthcare system as the public system and comparing and completely ignoring the private system. But our data is showing that over half of the people just go to private sector, and this is where a lot of the trouble is happening. Next slide, please. So what I just show you is at the outpatient level. At the inpatient level, the story is not that much more promising. We were going to do clinical review to look at people's whether people were given appropriate treatment, but then COVID started and we were not able to finish that. But we were able to collect some data on patient safety, looking at adverse events or medical errors using an international standard survey called the Hospital Survey of Patient Safety Culture. Almost no patient safety events were reported in any of the hospitals that we survey, and note that the hospital that we survey are actually quite high level, medical college hospitals and district hospitals already. So they're not like tiny hospitals. And less than 10% of the hospital staff would report that they ever submitted a safety event report. This is compared to about 45% among high income countries. We also collected information on for patients that were discharged from the hospitals, their satisfaction in terms of services. And not surprisingly, people have very low satisfaction in terms of personal aspects of care, including are they actually given advice? Do they have their problem explained to you very appropriately, etc.? And more worrisome is that the low-income people, the households who are in a lower caste, actually report worse satisfaction. So next, please. The more promising picture is that people do get access to care, in the sense that among the people who reported that they were ill, actually 90% of them said that they do seek care, meaning that there's not a lot of foregone care or people who need care but were not able to get it. So it's not about the quantity of it. It is really about the quality and the effectiveness of the care that people are getting. And again, next week, if we still have time, we can present some more details on access to care. For example, if you look at maternal and child health indices, there is definitely major improvement over time. However, what happened, the problem that still exists among maternal and child health is really inequality. Next, please. So overall, how are people satisfied with the system? So we borrow 3 questions that are commonly used by the Commonwealth in the United States when they do international survey, asking people what is their view. About 56% of the surveyed people said that their system needs major change. 33% actually says that it needs a complete rebuild. Next, please. This is just a summary of our key findings, and I'm not going to go through that because as my team goes through each of the outcome, they would actually repeat again and also provide the underlying causes. But this is just showing that we did comprehensively measure the outcome, the final outcome, and also the intermediary outcome in the framework that I presented at the beginning. Next, please. So some of the key takeaway is that if India wants to reduce catastrophic expenditure and impoverishment, a key question is how to pool our pocket spending into prepayment mechanism to cover outpatient services. India is now already thinking about extending its public health insurance coverage for outpatient services, but that's very dependent on whether the government would actually increase more spending in healthcare. So India has this a practice of announcing very big programs, but the public funding going into it is actually not necessarily there. However, a lot of people are already spending a lot of money in our pocket. So perhaps the more critical question is, how do you pool the existing out-of-pocket spending into some form of prepayment scheme? The second critical question is then, how do you reduce unnecessary spending on drugs, especially in the private sector? I'm just laying out to you, here are some of the questions that the team is working on in terms of how we will be designing reform options. And we also have to be looking at how do you translate money, even though if it is mobilized, into effective services. So we are designing different provider payment incentives and also different kind of accountability system and delivery system. So I'm going to pause here because today I want to focus on the assessment of Odisha's healthcare system and the key findings. And then I'm going to turn to Annie so that she can give you a bit more in-depth analysis of financial risk protection. And we'll leave plenty of time for discussion and for you to ask questions. But I just want to say that if anyone has any clarification question at this point, please feel free to raise your hand or just shout into the mic and we can do that as well. Thank you. Annie?
Okay, looks like we don't have any clarification questions. Wonderful. Okay, so I'm going to, as Winnie mentioned, discuss the sort of in-depth analysis of financial risk protection that we did for this project, which of course accompanies other analyses that will be presented, that Winnie just presented and that others will present next week. But first, I'll just talk a little bit more about how to think about financial risk protection in the state of Odisha and in India. You know, as Winnie mentioned, 24% of households incur catastrophic health expenditure in Odisha. This is CHE, which is defined as when 10% or more of consumption expenditure is spent out of pocket on health. So that's the measure that we use throughout the discussion of financial risk protection. So high in Odisha. Across India, in fact, about 16% of households incur CHE. And what I show you on the right is a national survey of India that shows catastrophic health expenditure for all the states, and Odisha is in red. And so it is actually has the second highest rates of CHE across India. And then if we think about other countries with similar levels of GDP per capita, India and Odisha in particular are much higher than sort of similar peer countries. As Winnie mentioned, 2/3 or so of out-of-pocket payments in Odisha go to pharmaceuticals, which is, you know, at the outset, you know, quite puzzling because the government provides healthcare free of charge, including drugs at public facilities. As I'm sure many of you know, the Indian government invests less than peer countries in health, however, you know, about just less than 1% of GDP versus 2.4% in peer countries is spent on health. And then, you know, India has a really large domestic manufacturing and production of pharmaceuticals. So that's sort of puzzling in the sense of India being, you know, the drugs available in India being less subject to global market prices for pharmaceuticals. So another thing, as Winnie mentioned, that makes sort of out-of-pocket, you know, and catastrophic health expenditure rates so high puzzling is that in Odisha, the government estimates that more than 80% of households are eligible for the state-run program, BSKY. And this program does cover the cost of hospitalizations at public hospitals and private hospitals, some private hospitals. And then it does not, however, cover outpatient care and drugs. So when we took a look at the literature, we found that, broadly, even rigorous quasi-experimental studies find that the insurance programs reduce OOP, but don't tend to have a statistically significant impact on catastrophic health expenditure. Moreover, no, we didn't find any, existing studies of many on catastrophic health expenditure in India that look at the private market for drugs in depth. The sort of really large household surveys, the National Sample Survey, the NFHS, they don't ask specifically about the use of care at private chemists, nor do they ask, generally if drugs are purchased there. So we really saw that as a major contribution of this analysis. I'm seeing a few questions in the chat. So let me okay, so I think Anushka has these covered. So this is sort of some of the motivation for taking on the work. Our key research questions were, why is financial risk protection so poor in the state? And with a focus on the health system and sort of drivers of financial risk protection, what can we say about the characteristics of healthcare that explain financial risk protection? And then really specifically, why is drug spending so high when pharmaceuticals are supposed to be free in the public sector? So I'll move on briefly to the methods. We collected a lot of household data, more than 7,000 households were in our survey and 30,000 individuals. To make sure we had enough information about healthcare use, we oversampled households with healthcare use and chronic illness. The results are all representative of the state based on weights developed on the sampling strategy, and then also methods to calibrate the results with the sort of the sampling with the census. And then just to be really confirm that our results and our surveys were representative, we extensively validated the sort of social and demographic characteristics of our survey with known, well done national or state level surveys, the national sample survey. We also collected an extensive amount of information from health facilities. We collected data from more than 500 hospitals and health clinics, and really uniquely, more than 1,000 standalone chemist shops. So I haven't seen any other existing literature that captures such an extensive scale of the private sector chemist shops. So that was also a major contribution of just our data collection efforts. To get a sense at drug stocks, we asked about 75 essential medicine list drugs in stock on the day of the survey. And they were also able to link almost more than 900 outpatient visits and a number of inpatient visits as well with the actual facilities that we surveyed. So that's also a unique aspect of our data collection and data. Finally, we have the geographic location of both the health facilities and the chemists. So we can kind of, as Winnie mentioned, look at market characteristics and the proximity of health facilities and chemist shops. To get a sense in particular about the drivers of catastrophic health expenditure using this cross-sectional data set, we employed Shaklee Decomposition. This is an approach to attributing the explained variation and outcomes to the covariates. And the idea is that you could have a significant and large association, sort of a coefficient that's statistically significant, but if the variation across the covariates of a given covariate is small, there's not much variation or explains very little of the characteristics of the sample, it's not going to explain much of the outcome. So it's just a way to think about how the outcome is explained by covariates. And effectively, what this approach does, or how to conceptualize this approach, is that a linear regression is run for every combination of covariates, then you compute the R squared, and then you calculate the contribution of each covariate to the R squared by computing the average difference in the R squared for regressions with and without the covariate. This is how to conceptualize it. And then for uncertainty, we used Bootstrap. And then just one last slide on methods. The covariates that we use in the Shapley decomposition span, our primary focus was healthcare determinants. So where did people go, what sector, whether they used insurance for hospitalizations, and also sort of the intensity of utilization, how many outpatient visits, inpatient stays, or drugs were obtained. And we want to control for other things that could potentially explain these healthcare determinants as well as spending overall. So we looked at the cause of illness, the severity of illness, whether someone had a chronic condition, as well as social determinants like wealth, age, education, and social group. So these covariates were used in all of our Shapley decomposition models. We looked at out-of-pocket payments per outpatient visit, out-of-pocket payments for hospitalization. We also use the continuous measure that informs catastrophic health expenditure, out-of-pocket payments, as a share of consumption expenditure, to look at sort of variation across these factors. And I'll focus on just those two. But we also did we also ran these models for catastrophic health expenditure and distress financing. So in terms of the results, I'm first showing you sort of just a different way to look at what Winnie has already mentioned. So this figure on the x-axis is that continuous measure that informs catastrophic health expenditure, out-of-pocket payments as a share of consumption expenditure, with the black line representing the CHE threshold. So anything beyond that black line, beyond 10%, that spending is considered catastrophic. And then what I have sort of smoothed over across our observations is the share of out-of-pocket payments broken down by the type of spending. So you can see in red that a major share, even as spending surpasses the 10% catastrophic health expenditure threshold, is due to drugs. And then you have some other categories like doctor's fees, tests, and then other tends to be people just selecting an other category. What we find here, as Winnie mentioned, 78% of cases are due to outpatient care, not hospitalizations. And if we do a little bit of a back of the envelope calculation, we estimate that eliminating the private sector spending on drugs would reduce catastrophic health expenditure by more than half. So would reduce Odisha's CHE to less than the national average. So, just thinking about the number of drugs, about 2.5 separate sort of drug types were obtained per outpatient visit, and using that same figure with out-of-pocket payments as a share of consumption expenditure on the x-axis, you see that the number of drugs obtained rises as the share of OOP of consumption expenditure also rises. Most people, the vast majority of people use the private sector for drugs. And in fact, about 15% of patients reported that a provider referred them to a specific chemist shop. So that could be one on the site of the facility or outside the facility. When we can compare OOP over consumption expenditure to the private sector use for outpatient drugs, you can see that it also rises as this measure increases. So, an important question is, are people just going to the public sector? Nearly 72% of people who are going to the public sector but using private sector drugs, maybe they're just unable to obtain the drugs that they need that are prescribed because drugs are not in stock at public facilities. And so what this figure, these sort of smooth density plots show you is that the mean of the 75 essential medicines in stock that we surveyed on the day of the survey, 31% were in stock at public primary facilities. About 50% of the private chemist shops had those drugs in stocks, and then public hospitals and CHCs had around 60% of those drugs in stocks. So, if you go to a public primary facility, your drugs may be more likely to be in stock at the pharmacies, but that may not be the case if you go to a public hospital. But the thing is that these drugs, the drugs carried by the respective institutions are not perfect substitutes. So public facilities tend to stock generics, whereas 84% of the stocks reported by the private chemists tended to be branded and branded generics. So they're really not quite the same product that people are obtaining in the public sector and the private sector. And we know from existing literature that people in India have strong preferences for branded and branded generic drugs. So this is a map of the geographic location of public facilities and private chemist shops. And what we found when we look at the distance between public facilities, public hospitals, as well as public primary facilities, is that there are many, many chemists surrounding these facilities. So for public hospitals, 93% have 8 or more chemist shops within a 3-kilometer radius around the facility. And then about 2 are surrounding public primary facilities. So a question about geographic co-location of private chemist shops and public facilities. When we ask private pharmacies, about 20% say they're registered as shops, not pharmacies. So that kind of puts them outside of the regulatory environment surrounding pharmaceutical shops. About 50% or more of pharmacy staff are unqualified, so meaning they don't have a pharmacy degree or something related. Most private pharmacies have, or a lot of private pharmacies have some sort of equipment used for assessing health. And when we ask patients about why they're using private chemists, especially for outpatient care, they tend to say that they have better stocks and variety of drugs and convenient hours. And in fact, when we look at people's satisfaction with their visit, they tend to be more satisfied overall with their use of private chemist shops, including for a number of subdomains. Of course, this is conditional on expectations for care, but nonetheless shows that satisfaction is high when people choose to use private chemist shops. We are able to compare the private chemist shops with public primary facilities. And while if you look in the first row of this table, while both public primary facilities and private pharmacies report being open close to the same hours, public primary facilities slightly longer hours, the hours per day worked by staff is much higher at private pharmacies, about 6 hours longer per day worked. Yes, the private pharmacies do also have some equipment. So when we link the patients to the facility, so there's 920 patients for which we are able to link someone who used care, the sort of characteristics of their care with the facility. What we see is this figure where the share of the essential medicines in stock by the facility is on the x-axis, and the share of patients using the private sector for drugs is on the y-axis. And you can see use of the private sector for drugs does tend to decline as there are more stocks. But even where all of the drugs were in stock at a facility, more than 60% of patients are using the private sector. So the story is not fully explained by just the drugs in stock at public facilities. So now I'm going to move on to the results from the Shapley decomposition. So these bars represent the share of the R squared, so the share of the explained variation attributed to each of the covariates. So this first figure, the dependent variable is log out-of-pocket payments per outpatient visit, and in blue are sort of the social and demographic characteristics. The orange are the sort of characteristics of illness. And then finally in turquoise green is the healthcare determinants. So what pops out immediately is that a major share of the R squared is explained by the number of drugs and whether or not an outpatient visit involved using private sector drugs. And this explains 2/3 of the explained variation in R squared. Then moving to out-of-pocket payments for hospitalization, here we see that the social and economic or sort of characteristics of the household, wealth quintile, and rural urban status do explain a bit more. But again, more than 40% of the variation is explained by just the use of the private facility. For hospitalizations, we didn't ask whether drugs are obtained outside the facility or in the private sector or not. So this could be considered a proxy for that. When we, a key interest is the role of insurance for hospitalizations, and that explained less than 7% of the variation. And in fact, just 15% of households reported having insurance at all, despite the estimate by the government of 80% coverage. And just 6% of hospitalizations used insurance. So finally, moving on to sort of at the household level, summing up all of the out-of-pocket payments and looking at them relative to consumption expenditure, this is the results from the Shapley decomposition. And in this case, we do see the role of utilization coming in. We see that the number of outpatient visits and hospitalizations do explain a substantial share of the R squared, more than 30%. But as Winnie noted, the utilization rates are not much higher, or they're about on par with the rest of the country. 4% of people are hospitalized every year. These are not, really high rates of utilization. So that leads us to turn to thinking about these sort of secondarily high bars. The number of drugs and private drugs still explain more than 35% of the R squared. So where does this leave us? I think it leaves us with a number of interesting conclusions, but also future directions as we continue to analyze this rich data set. The first is that the private sector for pharmaceuticals fulfills an essential health system function. It's the private sector that is supplying the drugs to the majority of patients. So really, it's important to think about this as a key aspect of the health system. But use of the private sector, because it requires purchasing drugs, is connected to the high rates of CHE that we observe in the state. We do see that public facilities have, especially public primary facilities, do not have a large share of the essential medicines in stock that we surveyed. We also saw that insurance coverage, isn't covering the things that are contributing to catastrophic health expenditure, outpatient care, and drugs. But even for hospitalizations, there seems to be a lack of awareness of eligibility and use of insurance. We have questions about the types of prescriptions that, whether providers are sort of purposely prescribing drugs not stocked in public facilities, but available at private chemists, including the branded drugs or this type of drug called fixed dose combination, which may take sort of a drug that you may be familiar with, combines it, and that is used to treat a certain condition, and combine it with things like vitamins to make it sort of a separate drug class. In the clinical vignettes, we do see that much of the prescriptions are branded, and as Winnie showed, seem to be disconnected from what is needed to treat the condition. Then I think a key question that we have is whether there is collusion between public providers and private chemists, whether public providers have some sort of interest in private chemist shops, whether they may own the chemist shop or have somehow benefit from the sales of drugs. We saw very little, just 15% referrals to specific chemist shops, but we did see a lot of geographic co-location. So just some questions about the potential for there being connections between the public and private sectors here. So that's all I have. I'd be remiss to not, say that this was a massive effort on the part of many, many people, including the team in GHP, as well as Oxford Policy Management, which managed the data collection, and many others who were involved in this work throughout. So thanks so much. I think we have some time for questions, so that'd be great.
Thank you, Annie. So let's open up for some questions and discussion. Do you want to unshare so we can bring more faces?
Yeah, Winnie, can I ask a question?
Yes, please.
Yeah, so thank you, Annie and Winnie. So I think it was a really interesting point right at the end on collusion. So I've seen previous studies where what they've done is go and look at what's in stock at the hospitals. And they find that the stocks of the drugs are there. But when you send mystery shoppers, the doctor says they prescribe the drug, they don't have it, but refer them to the clinic. And the doctor has an ownership interest in to a pharmacy, and the doctor has an ownership interest in the pharmacy. So the existing literature seems to point to this collusion. Yes. And that it's not actually lack of the drugs at the hospital that is the problem, is that the doctors actually have a financial interest in using the private sector. Now, there may be, as you say, there's a quality difference, as the actual brand of the drug may be different, but that seems to be a key issue. And I just wonder if you really think that's what's going on. I mean, those studies tend to be, on very small samples, but I just wonder if you think that's actually the mechanism that you're seeing here.
It was definitely a really strong hypothesis that we had. And one way that we tried to get at that, given our study design, was to ask the chemist shops if they had one of the owners was a provider, or, relatives of the owners were providers. And, not a lot of the chemist shop respondents said that was the case. Now, we could think about how much we believe those responses, but that was one way we tried to get at that we didn't see a lot of that connection.
Definitely, right. We definitely think that is a major underlying reason. But if you ask either the chemist or the public provider, of course, they won't tell you the truth because they're not supposed to be doing it. And in a way, when we were doing the geo mapping, if you use economic theory, and if the chemists feel that they are competing with the public sector, economic theory would say that they would want to be located further away, right? So that you can get a break the market share. But the fact that they actually locate quite close to each other, and that's part of the purpose of doing that, is to infer that the product that they're producing is somewhat complementary or have some ties in there. We also have a survey of the public sector providers and ask them how many patients the patients that you refer to your afternoon private practice. Again, we're not sure that those data is highly reliable or representative, but that definitely, but if you ask the people in the field, they would say, oh, of course, that's true. Or the public provider has some ties. And quite often it's not that they own the chemist, but it's usually like their daughter-in-law or someone who's related to you, but it's not you, that kind of thing. So yeah.
And if I can just ask a follow-up, you're on the patient satisfaction, you seem to be saying it's mainly out-of-pocket spending, but there's this evidence of large-scale absenteeism in the public sector in India. And I just wonder whether you think that wasn't mentioned as a sort of dissatisfaction, that providers aren't there when you go. Did that not come up as an issue?
You want to answer? It does come up in a sense that when we ask people why they go to the private, it's because, I mean, it comes up as the hours are not convenient. Maybe either Leanna, you can, and others can say more about the patient, the providers not showing up.
Yeah, so we did have a couple of variables that looked at ability to see providers as wanted, and all of those were higher amongst those seeking or receiving care rather in private pharmacies as compared to other outpatient options. So it did not look, at least in this setting, like absenteeism was more of an issue in this context, but we unfortunately weren't able to look at that directly.
Kevin, sorry, you're chairing.
Yeah, sorry, Winnie, I figured you could field the questions yourself, but I'm happy to jump in if you're like. I just had a follow up on David's point, which is that I totally get that people are not going to volunteer, their collusive practices to a survey interviewer. I mean, I wonder if you could just leverage and you may have already done this, the geography. I think you mentioned about 58% of the PhDs had multiple pharmacies around them. I mean, so presumably there's some fraction that don't have anybody around them, and providers do a bit better. The other end of that spectrum might be if there's so many concentrated around you, presumably the rents from kind of bad prescribing behavior are lower, and maybe paradoxically in those situations there's sort of less gaming of the system as well. But it seems like the first would be the not a perfect, but at least a signal of this kind of collusive behavior in the data.
Mm-hmm. Yes, no, that's a good suggestion. Anyone from my team want to add more to that?
So yeah, we're sort of at the outset of doing some of these more like market analyses and looking at the connection between, what drugs are in stock and public facility versus the chemist shop right outside, and looking at the sort of dynamics of patients, the sort of differences across those different configurations of connection between the public and private chemists. So yeah, I think that's definitely like the direction that we're going.
Shaker?
Yes, thank you, Winnie and Annie. Very good data. Following up on David's question, there is another way of collusion, which I'm not sure whether it's happening in Odisha, but definitely in some other states of India. And that is to have a kickback from the sales of a chemist to the provider. Definitely quite well documented for lab investigations, but anecdotally perhaps also operative for sales of medicines, which has been definitely experienced. And I think that's something that again could be explored, although I know that it's difficult. One of the ways to explore that will be actually to be in touch with the civil society and advocacy organizations locally, who perhaps know a little more than what will be told by the chemist and physician themselves, because that is clearly a social problem, and there are people who keep a tab on that. So, but thanks, very good study, very good presentation.
Yes, again, partial evidence is, I would say, many of the public hospitals that we have visited, I mean, just when you step outside at the front door of the hospital, I mean, it's just a few steps away, there's always a private lab there, and patients are always sent out to these private labs. And so lab is another source of the leakage in the public sector, definitely. And again, they're located very close to the hospital. And in this case, one might even say that you could probably have done your X-ray within the hospital, and why send out? It's not like they're getting a branded X-ray. Well, maybe they do. So there's a lot of interesting question of how they use slight product differentiation to get patients to go out to the private sector. And so again, the question is, are they actually getting necessary needed care and while spending a lot of money? Suresh?
Professor Yip, thank you. This is an outstanding study. Um, um, uh, Looking at the sheer number of drugs prescribed, most of them unnecessary, as you pointed out, was it a supply side push, or did you see anything that was seeing a demand side pull as well? In other words, was there something in the survey that assessed whether patients were happy if a provider just gave them one drug versus a provider who gave them 6 drugs? Oh, so, you know, is this a pull issue or a push issue? There's one other question, but I'll hold off for now.
Yeah, so we looked at the relationship between patient satisfaction and number of drugs prescribed, and we don't see a relationship between more drugs supplied and more satisfaction, or even sort of a look at like a target. Maybe people have some expectation for I'll get 2 drugs. There also doesn't seem to be a relationship between like sort of hitting a target and patient satisfaction. Yeah.
Okay.
I just wanted to add 2 points. One is in terms of collusion. I think another trend that is prevalent in India is kickbacks from wholesalers or discounts from wholesalers and pharmaceutical companies directly to chemists rather than to solo providers or private practitioners, or even outpatient care providers in the public sector, which is more prevalent, I think, in bigger cities and developed countries. But here we see that chemists earn their money because the essential medicines prices are all standardized by the government, right? There's a ceiling. So they earn their money through discounts from wholesalers and pharma companies directly. So that's why, one hypothesis, that's why they're selling the branded drugs much more, because they are more expensive and the discounts are much better there. Yeah, and again, from the clinical vignettes, which I think we will discuss next in the next session, we will talk a lot more about the supply side push, which is again a hypothesis that we have been following, that yes, doctors, it seems to be a supply induced phenomena.
Stefan, do you have a question?
I do. Great work. Congratulations, really, Winnie and Annie. This is terrific work. It's definitely very important for policymaking in India, but I think it's a great contribution to the financial protection literature in 2 ways. One is you're looking at a problem which is often overlooked, which is the private chemists, private doctors. And the other thing is that I think you're adding to the, there's many issues with the metrics of catastrophic health expenditures, but there's another issue which you mentioned, Winnie, which is that the semantic always focuses on big costs, acute shocks, whereas the repetition, patient pathways, the continuation of these payments is can be really important, as you just showed. So I guess 2 questions for me. One is, were you able, you showed on quality and then OOP, do you have, with the data you have, are you able to look at the concentration of those? In other words, that both the people who are receiving poor quality care are also the ones who are getting impoverished? And then the second question is that, have you, and I hope you have you thought about, what's next in terms of perhaps trying to do similar studies in other countries? The Indian setting is very particular, but where there's, also a great network of, private pharmacies, but, traditional healers, all these kinds of networks that, can be very significant on the OP side.
So are we planning to do another country? So initially we were going to do it in another state. Doing this turns out to be such a humongous job that doing it in another state, even if there were not COVID, we probably would have done it in another state like Maharashtra, which is a little bit more modernized, urbanized, to see comparison. So we don't have any current plan yet. However, when we design this study, what we have in mind is hopefully the way we design it would provide some sort of a framework or a new standard of study design or data collection that would allow you to do more systemic level analysis, right? So you're not just looking at household or you're not just looking at public, but you really are comprehensive that also look at from household to organization to even the market. So that's the idea, but it is not a small task, especially getting private sector. I'm sure you know, there's really no sampling frame. Right, so all the registration, they're not updated, you go look for them, they're not there. So what we ended up doing is that we use like 3 different strategies. One is from the household survey, we ask people where they go seek care, if it is private, and give us the name and the address. We add that on top to the existing official list. And then for each private provider, when we're able to find, we ask them who is the most nearby among them. So that was quite a challenge, yeah.
Maybe I could just jump in and say that might be the question about where to take this work in the future and which other country or state is maybe a good place to leave it for, and to kind of whet our appetite for the second version of this next Thursday. So I hope you join me in thanking the team, and I hope to see you all next Thursday.
I notice Patrick has his hand up. Patrick, you can send me us an email directly. We're happy to stay behind, but it is 2 o'clock, so I think those who want to leave, we should allow them to leave, but the team is happy to stay behind. So Patrick, you can continue.
I have one very quick question. Do you think it would be valuable, would you learn much if you did some day in the life studies with some of these patients, where you met them for breakfast and you followed them all day, and went to the clinic with them, and then saw them the next day? Is that possible? And if it was possible, would it be desirable? Would it be useful?
What would you be wanting to observe?
I want to learn about what they might be thinking or doing that aren't covered by the questionnaires.
We haven't thought about that for the case of India in this study, but this is closer to what China does, though, which is the sample size is much smaller. They're not necessarily representative, but they're purposefully selected. This is done actually by the Statistical Bureau. They select a group of households, and then they select a few interviewers who either live in the same village or nearby village, and they basically go to these households on a daily basis, record what do they eat the whole day, what do they buy every day, and over a period of time. So that's purposefully for getting accurate data on consumption and also for nutrition. And I can imagine that if you identify what is the subject that you want to observe, something like that can be done. So it has been, at least I know it has been done in China, and it is really following a household really, really in depth, rather than trying to be representative. But that's has been applied for nutrition or consumption. And we haven't done it in India.
Thank you.
And Patrick, just quickly, so we didn't do any patient shadowing or participant observation work, unfortunately, but for the patient satisfaction surveys, we did engage in quite a thorough validation process in which we did focus groups, one-on-one interviews, etc., asking patients, essentially scoring the relevance of items on pre-existing tools, which then informed which items were included in the survey tool. To your point about where were we missing things with prior instruments, etc. So not through observation, but through both focus groups and interviews, we did try to get at some of that.
Okay. Thank you.
All right. Well, thank you, everyone. And until next Thursday, and any one of you, especially if you're interested in the data, especially students, I mean, feel free to contact the team. There's actually a lot more in the data than we present. And I mean, for anything we haven't thought of already, it would be great to have the data used to produce anything that is useful for both research and for our conversation with the policymakers, because we're taking these results to engage national and state level policymakers to try to, first of all, aware them, alert them, these are the problems, and then moving to some kind of reform options as well. So thank you, until next week.